exercise and sudden cardiac death. Who is safe to sweat? As we all know, exercise reduces the atherosclerotic burden, reduce CV mortality and morbidity, and sports and exercise associated with a lower level of mortality, and athletes represent the healthiest segment of our society. But exercise may paradoxically trigger sudden cardiac death, especially in those with a structural or electrical substrate. What is the difference between sudden cardiac death and sudden cardiac arrest? Sudden cardiac death is defined as the cardiac arrest in a patient with or without non-existing, without non-pre-existing heart disease, in whom the mode and time of death are unexpected. If the person survives the arrest with the return of spontaneous circulation, whether with spontaneously or through CPR or through defibrillation, it is called sudden cardiac arrest. So some of the studies include sudden cardiac death and sudden cardiac arrest together. These are some of the people who had sudden cardiac death and sudden cardiac arrest. That first one, that Fabrice Muamba, he was a Congo football player. He was playing in England. He had a sudden cardiac arrest while playing, and he had CPR, defibrillation, and he was found to have hypertrophic cardiomyopathy. And he was put on ICD, and he changed his profession. He became a football coach later. That Christian Eriksen, as we all seen the Euro Cup, he collapsed while playing for Denmark, and he had a CPR and defibrillation, followed by it was searched for causes. There was no much causes. It is an unexplained arrhythmic death, arrhythmic arrest, and he was put on defibrillator, and he is back to the field. He is playing for Manchester United in English Premier League. That Puneet Rajkumar, the Kannada actor, he was doing gym during that Corona period. He had sudden cardiac arrest, and he had a massive heart attack. It was due to coronary heart disease. He was above 40. And Reggie Lewis, he was a basketball player. He had hypertrophic cardiomyopathy, and there was discussion whether he can be allowed to play and all. And while he was practicing, he had cardiac arrest and died. And James Taylor, another one, he was a cricket player. He was about to play for England. He was a very promising player. He had, when evaluation told, arrhythmogenic RV cardiomyopathy, and he was to retire. And again, this Ben Wells, also same thing, a promising player. Last year he had to retire because of arrhythmogenic RV dysplasia. And the Tamim Iqbal, recently playing for Bangladesh Premier League, suddenly had cardiac arrest. He had a massive MI, cardiac arrest, and died on the field. And our own professor, Professor Vijay Kumar, he was playing shuttle, and he had probably cardiac arrest. We don't know exact cause, most probably coronary heart disease. And Dr. Midun Kudalkar recently had, after the Goa marathon, he finished about 33 kilometers, and after that he collapsed and died. He had multivessel disease and massive MI. And Nick DiCarlo, he was a baseball player. The baseball hit his chest. After a few minutes, he fell down, and he had commotio cordis. He improved CPR and DC shock, and then he started playing after 1 week with a chest guard, so that he will not get hit by that, and again precipitate the commotio cordis. So incidence extremely variable. In US 10-year study, 17 to 24 years, it was 1.9 per 1 lakh athlete years. Italian study, Veneto, it was only 3.6 per 1 lakh year, 1 lakh athlete years, and declined after pre-participation policies. They were checked for different diseases, and it was reduced to 0.4, about 80% reduction in sudden cardiac death in patients. And Danish study, younger people, it was less, and more than 35 years, it was 6.64. And these were the studies that showed that it can range from 0.24 to 0.68 from high school to 35 years. So it is more in males, 10 times more common, more than 10 times in males, more in African and Afro-Caribbean blacks, and less than 35 years, genetic disorder, structural and electrical more common, and more than 35 years, atherosclerotic is coronary heart disease is more. Geographical difference also, US hypertrophic cardiomyopathy is the main cause, while Italy and some other European countries it is arrhythmogenic RV dysplasia. And sports, the basketball is the highest chance of sudden cardiac death, 1 in 3,000, and in Afro-American it is about 1 in 2,000. The value of expert cardiac pathology assessment, root cause of this is hereditary in most of the young people below 35 years, and SCD in young footballers, only 127 out of 617 underwent autopsy, only 20% underwent autopsy, and Europe also only 60% underwent autopsy. So molecular autopsy, that is post-mortem genetic testing and family screening, can yield about 40% in electrical disorders and cardiomyopathy. This is implication in secondary prevention as well as preventing SCD in first degree relatives. Etiology in lung, as told, structural anomalies, hypertrophic cardiomyopathy, arrhythmogenic ventricular cardiomyopathy, DCMP, myocarditis, idiopathic fibrosis, coronary artery anomalies, myocardial bridging, and in the electrical comes long QT syndrome, Brugada, catecholinergic polymorphic VT, WPW, and others. There are multi mitral valve collapse syndrome with some arrhythmogenic potential, aortic stenosis, aortic dissection, and commatio cordis and drex. This is 4 studies showing different patterns. That first one by Corrado et al. 2003, ARVC was the most common, followed by atherosclerotic, and second study there was coronary artery anomalies, myocarditis, and atherosclerotic coronary artery disease, and sudden unexplained death were common. And the other 2 studies, Maron et al., hypertrophic cardiomyopathy and coronary artery anomalies were common, and the last one, Finacciaro, he had sudden unexplained death was 42%, followed by idiopathic fibrosis and ARVC. This is the macro and microscopic appearance. The upper one, hypertrophic cardiomyopathy with myocyte disarray, and the second one is arrhythmogenic RV dysphasia with fatty and fibrofatty infiltration, especially in the RVOT, producing the arrhythmicity. There is some problem with athlete's heart. The modest increase in LV wall thickness and biventricular cavity size, increased trabeculations and bradycardia, QT prolongation and J-point elevation, and there can be overlap with hypertrophic cardiomyopathy, DCMP, arrhythmogenic RV dysphasia, long QT syndrome, and LV non-compaction as well as Brugada syndrome, and history ECG as well as cardiac MR may be useful to separate from these 6 causes. Once structural heart disease or channelopathy is diagnosed, there is a problem. Disqualification, probably that professional players have significant psychological stress, and there can be depression, and this test can be false positive also. So better to have a shared decision making, whether they can play or not, with that coach, that sports organization, that family, the doctor together, and they discuss the risk of sudden death, and they let them decide what to do. So prevention of sudden cardiac death, pre-participation cardiac screening, medical history, physical examination, ECG, and in selected cases echo, TMT, and Holter is needed. And the Italian study, pre-participation was made compulsory in the 2082, and there was 89% reduction in CD. Bystander CPR, the 2 crucial elements in survival. One is education of general public, bystander CPR, and deployment of AEDs in the public areas, and training and sports grounds, and training the general public about the use of AEDs. And greatest determinant will be the time from the collapse to defibrillation. How to prevent SCD during usual exercise? Assess CV risk and modify them. If needed, you can do echo, TMT, and classify them. Warm up and cool down gradually. Increase and decrease the exercise intensity. Listen to your body. When you have a symptom, you experience chest pain or dizziness or shortness while exercising, stop there and go and get evaluated. Hydrate well and monitor your heart rate. You have fitness watches nowadays, so that you can have a assess, monitor heart rate when exercising. Take home message, an abnormal structural or electrical cardiac substrate may promote fatal arrhythmias during adrenergic stimuli, especially in vigorous exercise. Inherited cardiac conditions more in young, and atherosclerotic in more in age more than 35. Structural abnormalities more common in below 30 years, and electrical abnormalities like long QT syndrome, Brugada, etc., and others like valvular disease and dissection and atherosclerosis are the causes. Overlap between atlas heart and these diseases, and postmortem genetic testing and family screening important. Pre-participation cardiac screening, bystander CPR and AED crucial in prevention, and more than 35 years assess severe risk, warm up and cool down, and listen to your body and keep a watch on your heart rate. Thank you for patience.